Hey everyone, we can go ahead and get started. My name is Sophie Maria, and I'm a consultant with Guidehouse supporting CDC's One Lab initiative. A couple of notes about today's webinar before we dive in. If you have any technical issues throughout the session, please feel free to email the One Lab inbox for support. That's at onelab@cdc.gov. If you have questions throughout the session, please insert them into the Q&A function. Please note that we have posted the link to the live captions in the chat, but please be sure to keep both the captions window open in addition to the webinar. We'll start by discussing a relevant One Lab resource, then we will go through some introductions. We'll have about a 10-minute Q&A session at the end where we'll review all of your questions and do our best to answer. Today's session will end with a discussion of upcoming events. Next slide, please. For today's webinar, we will be leaving the chat feature open for your engagement. When you're utilizing the chat box, please keep in mind the appropriate rules of engagement. Feel free to use the chat to connect with others by reacting to what you're hearing, sharing your experiences, and asking questions to the fellow participants. If you have a question for the presenter, however, please make sure you're using the Q&A function, not the chat. Additionally, please engage with respect and professionalism. Any inappropriate language, improper conduct, or any form of discrimination may result in removal from the webinar. Please ensure your comments are relevant to the topic, and if a moderator gives direction regarding chat behavior, please comply accordingly. Lastly, please notify moderators if you experience any technical difficulties or observe any disruptive behavior. I am now excited to hand it over to our One Lab lead, Alicia Branch, to share today's relevant resource.
Thank you, Chelsea. Oh, Chelsea. I'm so used to calling Chelsea. Thank you, Sophie. Before we begin the main presentation, as Sophie stated, I will give a One Lab resource. It's the Individual Quality Control Plan, better known as IQCP. It provides a framework for customizing a quality program for your testing at any testing stage, any testing type, or the environment, whether you're in the lab, as like our speaker, or a pharmacy. By following the IQPC steps, you can identify potential sources of error you may not have considered or establish appropriate QC for. It also will help you to look at the quality practices to lower your chances of error in your facility. In the chat, you'll find the links to the IQPC step-by-step booklet, and you can also get a hard copy mailed to you free of charge just by requesting via email. And again, you can just click on the link and follow the steps if you actually want a hard copy. Next slide, please. This is our external speaker disclaimer, and I will read it. Slide decks may contain presentation material from panelists who are not affiliated with CDC. Presentation content from external panelists may not necessarily reflect CDC's official position on the topics covered. Next slide, please. Excuse me. And I'm excited to introduce our speaker for today. It's Dr. Matthew Meyer, a second-generation independent pharmacist from Shooterton, Wyoming, who currently owns and operates 2 independent retail pharmacies with his brother. Matt started providing point-of-care testing in 2009 when he opened Hospital Pharmacy West in the Shooterton Memorial Hospital Medical Arts Complex. He provides screening for influenza A and B and strep throat. Since then, he's expanded into molecular diagnostic point-of-care testing, urine drug screening, hemoglobin A1C, lipid panels, and pharmacogenomic testing services. He has spoken at numerous conferences and conventions on pharmacy-based point-of-care testing, received several prestigious awards, and contributed to the development of the National Community Pharmacy Association point-of-care playbook. Matt is always eager and enthusiastic about advancing the pharmacy profession and collaborating with other healthcare providers. Our speaker for today is Dr. Matthew Meyer. Over to you, Matt.
All right, thank you very much. We'll get going here. We should be up and rolling with the role of pharmacists in point-of-care testing, ensuring quality and safety in the community pharmacy setting. So thank you very much for joining us this morning, and hopefully we've got at least a few things that you will find interesting. Intended audience today, again, being in the pharmacy setting, primarily was designed to be delivered to pharmacists, pharmacy technicians, but really any other healthcare provider operating in an office or community setting, not directly attached to or
Matt,
affiliated with.
Oh, you're not sharing your slides. Just so you know, you're not sharing.
Oh, it's not sharing. Okay, let me
No, it's
jump
not.
back in here. Share. Okay, here we go. How about now?
Yeah, click on the
presentation.
Yeah.
Yep. From beginning. How about now?
It's perfect.
Okay, awesome. Always something. All right. So again, really designed for pharmacy technicians, anybody that's out away from your typical lab or clinical laboratory, hospital-based central laboratory system. And upon completion of presentation, hopefully participants have at least a basic understanding of the need for implementation processes of the following course objectives, to define point-of-care testing and opportunities and challenges in establishing quality point-of-care testing services, recognize characteristics for ideal sites for community-based POCT, understand the importance of quality assurance programs and the accuracy of test results, how education and ongoing training of all laboratory personnel is definitely required for consistent, highly accurate labs and test results, and understand the role that each test manufacturer plays in the development of those policies and procedures. Just the next slide, if it will advance here. Why are we going back up? Okay. So again, we've read all of that. There were no financial disclosures that needed to be made regarding this presentation, though I have previously been compensated for presenting on point-of-care testing programs by Abbott Rapid Diagnostics, and I'm also an active board of director member for the buying group Association of American Pharmacists, or AAP. So before we get going, really, in terms of the quality assurance programs, what is point-of-care testing? This is kind of a basic understanding and definition of what it is and where it's performed. So point-of-care testing is any type of clinical laboratory testing that is conducted close to the site of care. That could be patient's bedside, pharmacy counter, physician's office, and that's going to generate test results within minutes. Depending on the manufacturer's indication, those test results can be used for monitoring, screening, or diagnosis of disease, and may be completed by healthcare providers, clinical laboratory personnel, or even patients at home. One thing that is required for point-of-care testing is that it always utilizes some type of testing device. There is a sample collection and preparation, and results in interpretation and analysis of those test results. And CLIA, or the Clinical Laboratory Improvement Amendments ratings, identifies the complexity of testing based on, or has three levels of complexity of testing, from waived, moderate complexity, and high complexity, with all waived tests becoming moderate or high complexity if your manufacturer procedures are altered. So again, really what makes a waived test is that as the providers, you are following the manufacturer's instructions on how to conduct those tests as written by the manufacturer. Any deviation and it is no longer a waived test. And again, point of care testing sites include pretty much anywhere in the community these days: physician's office, assisted living facilities, patient homes, schools, nurse's office, anywhere basically that you can do something as simple as self monitoring of blood glucose. So what is kind of the different characteristics of the CLIA ratings? Where we're going to be primarily focused our wave tests in community pharmacies, though there are some community pharmacies that have gone ahead and become moderate complexity. The majority of us are going to stay probably in the wave testing space, and again, that is going to be the simplest of the approved tests, of the point of care tests. They are tests that may be completed by members of the general public without any form of formal laboratory training. And one thing that really defines a wave test is very, very simple specimen collection with minimal manipulation or preparation of samples. So we're talking 1, 2, 3 steps from sample collection to running the test and results interpretation. It's also, they have a very, very simple, generally qualitative results in nature. So minimal interpretive analysis is required. Generally, yes or no answers are showing up with those wave tests. And the other big unique characteristic of wave tests is that kits are generally sold in complete units, so that everything that's needed to perform the test is included altogether. And there is a very, very low likelihood of failure, or I should say there's a low likelihood of patient harm to come from failure or improperly following the instructions, versus where we start to look at moderate and high complexity tests. You know, those definitely have multiple steps in either sample collection, preparation, or running the actual test analysis. It does require specialized training and knowledge of the tests and the laboratory procedures. So again, you'll hear me reference this quite often, is that all CLIA wave tests become moderately complex tests if the manufacturer's procedure is not followed or deviated from. And with a CLIA waiver, you are only authorized to perform tests that are CLIA waived. And moving on. So where are we seeing point of care testing being provided, and what are some of the ideal characteristics of where point of care testing services can be most beneficial? Honestly, ideal site characteristics, these tests need to be available with respect to the patient's schedules. Thinking of how laboratory tests are normally run in a centralized lab, you've got patients, scheduling an appointment to go to their provider, whether it's a physician, PA, nurse practitioner, being seen by that provider, having a lab ordered, going over to the lab, getting their blood drawn or getting their specimen collected, having the lab run that test, send the results back to the provider, and then the provider getting back in touch with the patient maybe several hours later, giving them the results, calling in orders, and then if treatment's needed, heading to the pharmacy to get those treatments. So we take a look at something like influenza, where really we need to initiate antiviral therapies for those positive tests within the first 48 to 72 hours. And we can really see that time window cut out our effective treatment option or treatment window very, very quickly. So ideal sites, again, are going to be open longer probably than physician hours, normal hours of patients at work, and are walk-in as needed. Appointments not required. They're also going to have people that are qualified to review results and development treatment plans. It's great to develop those treatment plans, but if the treatments aren't on site, that's another step. That's more time. That's more inconvenience for the patient. Ideally, we want all those treatments to be in the same place where that patient is getting tested, should be in close proximity to the patient's home or work, and then have established documentation and follow-up procedures. A big one that pharmacy is still lagging a little bit behind in is the ideal site should be able to bill third-party insurances or bill the patient directly, depending on how the patient wants to pay and what those options are. And then we should, again, be able to have those test results integrated in with other providers' EHR systems and have seamless cross-communication between the testing site, the treatment plans that are written, and the treatment that's given to the patient in follow-up. So how does community pharmacy or how does community retail pharmacy stack up with that? Generally, pretty well in terms of the ideal site. We're looking at pharmacies generally are open, beyond those hours of standard primary care. Some are 24 hours. Pharmacists are available without appointment. They are just right behind the counter, very accessible to the general public and to patients. Pharmacy school and education does include clinical services training and is the second longest academic program with clinical training with 6 years minimum. You've got medications on site for either test and treat or symptomatic treatment, depending on test results and symptom presentation. And 95% of Americans live within 5 miles of a pharmacy. We're starting to see EHR and clinical encounter documentations being in place and being utilized both in pharmacy management systems and some integrations through different organizations of being able to take those notes from CPESN or state registries and actually seamlessly integrate those into EHR. And the other big thing with pharmacy is, at least for the majority of the pharmacists that I've worked with, the pharmacists generally know their limits and aren't really looking into getting in over their heads. So we have no problems with referrals and are very comfortable making referrals when something is presenting that's outside of our realms. So in all honesty, it's community retail pharmacies are one of the ideal locations to provide point of care testing services. So what about laboratory standards and regulations? We've definitely seen some changes here over the last 40 years with CLIA, which is the Clinical Laboratory Improvement Act, or amendments. First introduced in 1967, with the big amendment coming in 1988, which is still called CLIA 88. And then we've got a couple other dates on there that the CLIA was amended once again. CLIA's primary purpose was really to just establish quality standards for laboratory testing being performed on human specimens for the purpose of diagnosis, prevention, treatment of disease, and health assessment. It was there to improve the accuracy of the tests, increase provider confidence in the results of those tests, and to reduce costs from repetitive testing. Prior to CLIA lab result interpretations, a lot of the individual manufacturers and tests were having to be reordered anytime that patients were transferred in care, because you didn't really know what exactly those test results may or may not have meant. So when we move through that progression, there are several different certification types that each laboratory or facility can be assigned. Again, focusing primarily on community pharmacy, our primary certificate that we're going to be talking about are the certificate of waiver. One thing that is probably most prevalent with CLIA waiver tests, very, very simple methodology. And because it has very simple methodology, it helps ensure, again, the accuracy of the test with no to low risk of harm if performed incorrectly. Wave tests include home test kits that are collected and ran and analyzed by the patients themselves. Simple yes or no answers in terms of results. Facilities, when you apply and are issued a certificate of waiver, may only perform wave tests and must follow manufacturer documented procedures for each of those tests. The facility must list out on the CMS 116 form exactly not only which tests they're going to be performing, but also the manufacturer of those tests as well. And then that application, after that is all completed, is sent on to the state agency where the facility resides. So again, majority of what the tests that we're going to be talking about today are following under the certificate of waiver. There are other CLIA certifications, obviously, for more complex tests, with the next step being a certificate of provider, or also called the perform microscopy procedures. This is a lot of times what you're seeing also in physician's office, and this particular certification is provided to labs or providers that are conducting moderately complex tests performed by a provider when transport of the specimen could affect the accuracy. So again, we're talking primarily infectious disease, where we're utilizing a microscope to identify that infectious disease, with some examples of being wet mount prepared slides, pinworm exams, or potassium hydroxide slides. The last two kind of go hand in hand and are the most complex, or allow the most complex tests, laboratory tests, to be performed on site at the lab, is the certificate of registration and certificate of compliance or accreditation. And really, the certificate of registration is what is issued when a lab first applies to perform moderate to high complexity tests prior to being inspected by the state health department that is responsible for conducting those inspections. When the application is sent in, that automatically prompts and notifies the state health department that the inspection is required, which is then scheduled. Once that inspection has been completed, as long as the facility is within meeting the CLIA standards and regulations, then that certificate of registration becomes the is reissued as a certificate of compliance or certificate of accreditation. So again, mostly focusing on CLIA wave tests here and waiver of certification. So one thing that I find very interesting is, why are we seeing pharmacies getting involved with point of care testing and other facilities, is really the estimated and projected growth for point of care testing over the next 10 years. In 2023, we saw $36.74 billion worth of revenue globally that was directly attached to point of care testing. And again, this is after COVID-19, that rush. So if we go back even further, that number, this is going to be an even bigger increase. But just in 10 years, from 2023 to 2032, the projected estimated revenue is up to $90.25 billion projected. That's 3 times. So we're definitely seeing a need and desire for point of care testing due to those rapid results and rapid treatment initiations and convenience from patients and providers alike. So this space is only going to continue to grow, which is, again, another reason to make sure that if we are contemplating and offering point of care testing, or are already offering point of care testing services, that we make sure that the services that we are providing are as reliable and accurate as possible. So community pharmacy and point of care testing, again, we've gone over a lot of the pharmacy strengths already. You know, one strength that I failed to mention earlier is patients generally tend to have multiple providers. They generally only have one or two pharmacies. I say one or two because of all the specialty craze right now and mandatory mail order and whatnot. But really, I mean, in the pharmacy, you look at a pharmacy profile, and again, you will see multiple providers listed, multiple different medications. It is also one of the few places that there is at least a very good chance that the medication and vaccination records are going to be as accurate as we can hope for, especially with pharmacy management systems now integrating in with vaccination state immunization records to automatically download those into the pharmacy management system. We're seeing e-care integrations that are allowing communications directly to providers into the EHRs. So again, we've talked about and discussed the strengths for point of care testing in pharmacies. As far as the barriers as point of care testing providers, really this is going to vary by state. We see a great difference in what is written into the state's scope of practice for pharmacy, and also, you know, limited provider statuses, statutes by state that recognize pharmacists or pharmacies as non-qualified healthcare providers. There's limited test and treat legislation on the books in these various states, which again, we're seeing more and more states passing them, but really need to make sure that you are operating within your state board of pharmacy scope of practice, and also within the legislation passed by your state governments. You're also seeing differences with collaborative practice agreement requirements by state. Another area where we are very, very far behind is the third-party billing knowledge and utilizing of evaluation and management billing models. Very few pharmacies or pharmacists have medical contracts with third-party medical payers. We've got the drug benefits, which is an entirely different billing platform, but not the medical contracts. So that does limit some of the patient access that could be there if we could get pharmacy to get caught up on the third-party billing side. We also see pharmacies are generally very, very cramped for space. So introducing any new services introduces new workflow challenges, space challenges for storing more product on our shelves in environmentally controlled areas, and also just counter space required to perform point of care testing. Limited or no policy and procedure development, particularly in the independent market. You'll see quite a bit more standardized policies and procedures at the box stores. Independent pharmacies don't tend to write down and have those policies and procedures developed. You see various levels of training with, you know, pharmacists and staff, depending on what their background is, when they graduated, and what kind of experiences that they had during their clinical rotations. And you also see issues with establishing isolation and cleaning quarantine areas, both for the patients and for the laboratory equipment itself, just again due to space constraints. So those are all barriers that need to be evaluated and addressed before really jumping head over heels into getting into the point of care testing programs. So when it comes to developing a quality point of care testing program, we see several characteristics that indicate or are associated with reliable and accurate point of care testing programs across the board. Yes, appointment of a laboratory director, it is required on your CLIA application, but it is really important who you pick as your laboratory director to really get that program up and going. This person is going to be your champion for all of your laboratory services and needs to be engaged and enthusiastic about it. They are going to be very instrumental in the program development and implementation of all the policies and procedures, the training requirements, the documentation. So really, really want to choose who that director is that's going to be in that lead role for your laboratory services. You also see, you want to make sure that any laboratory personnel and pharmacy staff are having initial training upon hire or moving into that department, and also that they're completing annual training requirements. Annual training should include things regarding safety, both for the staff as well as the patient, sample collection techniques, testing procedures, specifically the testing procedures that for the manufacturers of the test kits that you are utilizing. Results interpretations, knowing when a result is positive or negative, but also what to look for in terms of what may or may not be an accurate test result. They need to be trained on documentation of what needs to be recorded, how long it needs to be kept, and what goes in the patient file, what's communicated to the ordering provider, as well as environmental and cleaning trainings, workflow, etc. We also see this CQI, continuous quality improvement programs, and that's going to include all aspects of your laboratory program, from documentation, training programs, and your CQI needs to be reviewed quarterly for some of them and no less than annually for the rest. Probably the biggest push and the most labor intensive, at least during startup, is the policies and procedures development. It's generally a very, very extensive document that's going to outline all aspects of the service, include the who, what, where, why, when, and how. It is a critical component and must be enforced after written. It should be reviewed and updated at least annually and as needed when your CQI identifies procedural problems or when new tests are added or removed. Okay, all of those things are great, but if you're not having director and management meetings with your staff, if you're not relaying that information and having those open lines of communication on what's working and what's not, all the great planning in the world is going to fall well short. You should have director and management meetings with your staff at a minimum annually, probably quarterly, depending on how many tests you're offering and the number of services that you're doing. And the last thing that needs to be well established when jumping into this market is you need to make sure that you have adequate and reliable supply lines. And that generally includes multiple suppliers for the same products, whether they're ancillary supplies, test kits themselves, all of it. So determining what point of care services, again, I know that we're talking about quality improvement, we're talking about quality testing, but really that all starts in terms of truly what point of care testing services should you or can you be offering at your site. And before you can write your policies and procedures, you have to know what tests you're going to be going out there and offer and market. So starting off with just the most basic and simple of questions. What other services are currently available in your area or market? Is there some disease process that needs testing services? Is there a patient population or group that is stressing the current laboratory testing services that are available that you can tap into? Are you going to focus on screening or offer diagnostic tests? Thinking antigen or molecular diagnostics in terms of infectious disease, or if you're wanting to jump into the urine drug screening, are you just going to be offering the screening tests, or are you going to, after those screenings are conducted for employers, mail those off for something like GC mass spec confirmation? What are the advantages and disadvantages of offering both? Generally, it's going to be cost versus accuracy and reliability of test results. What tests are currently available to you to order from your current vendors? What potential vendors are out there that are currently looking to potentially supply? Do they have an adequate supply for the number of tests that you're going to be needing? And what about ancillary supplies that aren't included in those test kits, such as PPE for your staff, cleaning supplies for infection control? All of those kind of questions need to be answered and have an answer prior to being able to determine what tests your facility is going to offer. What are the startup costs, maintenance costs, storage costs, and opportunity costs? Everything costs something, and part of your CQI is ensuring that your service is financially feasible. Profit is not a bad word. Anytime that you're doing a quality improvement program, you need to be able to ensure that at least somewhere your financial markers are being reviewed in your CQI, at least annually. Because the greatest testing program, if it's not financially sustainable, is not going to be around for very long. Again, do you serve a unique population group that requires specific monitoring? Do you have a large warfarin group that still needs prothrombin times, INRs that could be conducted in the pharmacy or in the provider's offices versus going to a centralized lab and having that blood drawn? And where are you going to have space dedicated to the lab itself to conduct those tests, and the supplies and storage of the supplies? Again, site characteristics, I'm not going to go through each and every one of these. Again, it comes down to when you're making those initial considerations. There's administrative considerations and physical considerations. How big is your analyzer? How much counter space do you have? How much environmental controlled storage space is required to store all your new equipment and test kits? You have to make sure that your PPE is accessible to where your lab staff are going to be providing sample collections and running those lab tests. Need to minimize test cross-contamination. And one thing that caught me off guard, hey, you've got to start monitoring the temperature, humidity, and exposure of UV light to all your test kits. And not only can you not just throw a regular thermometer up on the wall, the environmental, to see how much, it's got to be lab certified, and it has to be sent in and standardized every 2 years. Administrative considerations, administration's going to determine kind of what your test kits are, whether they're single or multi-panel analyzers and all that fun stuff. But really, is your administration and management behind this effort? Are they making sure that you're having adequate staffing levels during high traffic times so that those tests are getting turned around in a reasonable time, that you're not exceeding the recommended time between running the analyte and the storage and the sample collection? Daily cleaning procedures, and those need to be documented, that every day before you open or before the lab's open, that it's getting cleaned up, that the equipment's cleaned. Again, we've talked about supply levels, but also getting these other procedures ready, making sure that the reporting procedures are in place, testing protocols, scope of service, quality control procedures, and getting staff input. I can't emphasize that enough, that your administration should be talking to the people that are down in the dirt, in the field, that are running these tests, to identify where these problems are, and what needs to be improved. So once you've kind of done your homework, done your research, which tests are available that are out there that are point of care waived by the FDA, that are CLIA waived tests. So included the link there for the complete list of CLIA waived tests from the FDA. The nice thing about that is, jumping in to the third-party billable side, all the CPT codes are also included right there with the test name and manufacturer, that can be accessed at that link. But common tests that are generally considered, again, this is nothing new probably to most of you: blood glucose and A1C, upper respiratory infections, lipid panels. We're seeing more HIV antibody screenings, which also requires some disease-specific training for consultation, depending on those results. Hep C, and now we're seeing some point-of-care testing, molecular sexually transmitted disease test kits and analyzers that are small enough to be portable and that are point-of-care. So definitely seeing some development in terms of what can be monitored with point-of-care testing. This is just, again, one of the pages from that resource link showing your billable codes, test name, manufacturer, and the intended use. So again, as CLIA waived tests, we've got to stay within this manufacturer approved and intended use of the tests. Otherwise, they are no longer CLIA waived tests. They become moderate complexity, and you have to make sure that you're playing within the realm of your certification for your training and your laboratory. So again, an example is an A1C test indicated for screening as a waived test cannot be used officially to diagnose diabetes. Otherwise, it becomes, officially considered a moderately complex, because again, it's outside of that intended use. So when selecting which manufacturers, test selections, what criteria should you be evaluating? This is kind of a short list, but one of these are probably the main questions that I would ask, or I do ask, prior to choosing who I'm going to partner with, is test performance. Not only how big is my analyzer, what's the testing procedure, how long is the runtime, what are the specimen collection requirements, are we adequately staff trained, do we have the space for it, sensitivity and specificity, obviously, as well as positive and negative predicting value for diagnostic or screening tests, purchase price, startup costs, features, the accuracy of the tests, the reliability of the equipment, but also, probably more importantly, with upgrades are, is it expandable? What are the maintenance fees? All these things need to be considered. Cheaper in the beginning is not always more cost effective in the end. It can actually end up setting you back more if some of this equipment cannot be upgraded in the future as your services expand or as regulations change. Software and maintenance. Can we see the device integrate directly into the pharmacy management system? Or, I'm sorry, I've got a typo there. Should be EHR, electronic health records. If those are options, those are huge time savers. They decrease the chance of missing that quality assurance step because it's automatically being transmitted electronically as the test is completed. It's being documented for you. Cloud-based updates, or does somebody need to come on and physically plug in and update via USB or some other method in order to update your equipment, as well as technical cleaning and care requirements of your devices. So again, picking devices or at least evaluating devices that can eliminate some of the manual entry of your quality assurance program can not only improve the quality of your tests and your CQI, but can also reduce your costs by decreasing the amount of human time that's having to be spent manually documenting some of these logging requirements. Manufacturer training and support. What's the manufacturer doing for you, particularly when you're starting? They are probably your greatest resource out there anytime you're offering a new CLIA-waived test. Again, you have to follow their documented procedures in order to utilize the test and maintain it as a waived test. So utilize them for writing your policies and procedure manuals. Get those forms and modify them for your organization, but they are definitely your best resources for the tests that they are producing. And then ancillary supplies. What supplies are you going to need that aren't included with those test kits? Whether it's specimen collection materials, quality control materials, disposables, all those need to be considered when calculating costs, but also, again, from a quality standpoint, a supply issue. It's also, how often you're going to be running your quality control tests. That's recommended per manufacturer per test. Some of them are anytime that you open a new box of test kits. Some manufacturers recommend it for each order, whether that's 1 box of 10 or 10 boxes of 10, you only need to run that quality control one time. Some recommend each and every lot change. So again, using your manufacturers and their documented procedures will save you a lot of time and effort than having to go back and recreate the wheel there. Staff training requirements is kind of the next big topic in terms of, unfortunately, no, I shouldn't say unfortunately, but a lot of times the quality of your laboratory and the quality of your results is often determined by the quality of your laboratory staff conducting the specimen collection and tests. And a lot of times the quality of your laboratory staff is reflective of the quality of the training program that your administration has put in place for your lab. So if you have a well-designed training program, you're generally going to have developed quality laboratory personnel. Anyone working in your lab should have to complete an initial training program for every single test that you offer or are thinking of offering, and needs to have annual refresher programs to ensure adequate knowledge and skills. Does not matter where they've come from, does not matter how many years that they've had in the field, whatever their background is. When they come and they are in your lab, following those procedures, making sure that it's documented, just helps ensure that you're getting the best performance and the best results that you possibly can from your point of care testing services. Again, when we're talking about adequate knowledge and skills, it should include both general knowledge and also include a skills proficiency assessment, at least annually or more often as needed to correct deficiency. When we're talking about proficiency testing, it's from start to finish. So it includes everything from patient intake, proper sample collection, test administration procedures, results interpretation, documentation requirements for each test that you offer. It's also a good idea to have a list somewhere and review with each staff member potential risks that contribute to inaccurate testing results and how to minimize those risks. Again, identifying where mistakes or problems tend to commonly creep up, and to be aware of those can minimize the risk of those actually affecting your lab results. So just some very, very basic key trainings include bloodborne pathogens, again, manufacturer device specific training, infection control and hygiene for staff and patient protection, These are labs. It is protected health information. They all need to have HIPAA training. Emergency response and first aid, needle stick prevention. Again, that disease-specific training. So if you're offering something like HIV screening, that requires, a specific disease consultation for any positives, making sure that those training requirements are being conducted each and every year, as well as continuing education requirements in order to stay up to date with guidelines and resources that are available out there. If you're just getting started in the point of care testing arena, some potential training resources and programs that are very good, very broad. Probably the first starting off with, the CDC, ready, set, test, patient testing is important, get the right results. Very broad, just touches almost every specimen collection and test type of point of care testing that you're going to see or be exposed to in that one training guide right there. But as we move further down the line, you see the OSHA and CDC preventing healthcare associated infections. From the pharmacy standpoint, you can definitely do something like the NASPA pharmacy-based point of care test and treat certificate program, which is nice. You can turn around and get a train the trainers so that you can conduct those trainings in-house on your own. But other resources that are again monumental to the success of your program are going to be the manufacturers of the tests that you're utilizing. And you can find some very good training material on YouTube. You just need to go sure and make sure that it is a very credible source to get some of those movies to see certain collections and sample preparations being conducted versus trying to read about it and see it on paper. So again, I just included one of our training posters that we keep right in the collection areas. It's up on the wall at all times. It's technical tips for collection of a nasopharyngeal swab. We've got nasopharyngeal direct and oronasal all right next to each other. But again, before each and every time that somebody's going out to collect that sample, boom, it's right there. Just take a quick look. Remind us of what we're trying to accomplish and where we need to be in order to collect the best sample that we can. Oops. So kind of a broad quality control program. What are the goals of a quality control program? To put simply, is to ensure accurate test results over time. We want to make sure that we are as accurate on test 1 as we are on test 1000, as we are on test 10,000. It's going to improve patient safety, and it's going to maintain compliance and regulatory standards. From a business aspect and from a local, community care providers standpoint, it's going to increase your confidence and providers' confidence in the services, the lab services that you're providing. It's going to get you more referrals. It's going to get more positive word of mouth about your laboratory services out in the community to other people. And then, again, can't emphasize this enough, for waived testing, your test package inserts from each manufacturer includes your quality control requirements for each test device and should be copied directly in your policies and procedures manual directly from that package insert. Must be documented, keep it on file. Don't ever take shortcuts and follow the procedures to the letter. It's also going to tell you how often those quality controls need to be conducted in order to stay in compliance, and make sure that any quality control results that are outside of the limits that are not expected, it will have the actions and steps that need to be taken, from quarantining the device to taking it out of and replacing it, depending on what the quality control issue is. There's a lot of bullet points on this slide. We're getting near the end though, and policy and procedure manual. This is really going to be kind of the Bible in terms of your laboratory procedures. Should be I think broken down into chapter or should be separated by test, and each test section should have a policy that includes all of the following information. The intended use of the test, what the test is there to screen for, whether it's screening, diagnostic, the disease, why are we using the test, and explanation of the test. Again, what is the, how does the test itself work? Principles of procedures. Steps 1 through Z, or A through Z, of how the test is carried out. Specimen collection and handling, transport and storage. Should outline how much time you have from sample collection to when that needs to be analyzed, if it needs to be stored, under what conditions, can you transport in viral transport media, what types of viral transport media can the specimen be transported in, what's the stability, the required reagents and materials, what kind of swabs you're going to need, storage and stability of reagents, how long are those agents going to be good on the shelf, do they need to be stored at specific temperatures, your quality control procedures, what needs to be conducted, how often it needs to be conducted. Again, should have a section going over your test procedure, A to Z. Here's that precautions in terms of common errors, common results, common things that can interact or interfere or provide an inaccurate test result. What result interpretations look like, what a positive means, how it appears on the test device, and what kind of information you can deduct from that positive or negative, and also the test's limitations. There is no perfect test. Every test has a limit. Every test has some type of false positive or false negative. Conditions of authorizations for laboratory use. And then performance characteristics, including analytical studies and references. All of this information is going to be available either in the package insert or from the manufacturer of your point of care testing kits. Okay, documentation requirements and forms. Again, we've all heard if you don't document it, it hasn't happened. This is kind of just a condensed list, but again, things that I look for in terms of what's in my policies and procedure manuals, as examples of what forms that need to be filed and need to be filled out. Obviously, we have to have our test procedures. I shouldn't say obviously. You should have a test procedure approval and review sheet that's conducted annually. Basically, your laboratory director is going through reviewing what tests you're offering, that you're going to continue to be offering them, and that that evaluation's been conducted. That's still an applicable test to your community, to your site. Next is going to be your test verification form, and that is conducted each time. That is filled out each time a test is conducted. At a minimum, should include the sample number, your expected results, the actual test results, the staff who completed the test, and any comments. External quality control documentation. Again, this is the quality control methods and procedures that you as laboratory staff are performing. They're your positive and negative quality controls, which is different than your procedural controls, which is right down below that. But your external quality control documentation sheet should include the date, the assay that was being having the quality control run on, your instrument ID, so the serial number of the device that's being used, your test kit lot and expiration date, your positive control lot and expiration, your negative control lot and expiration, the positive control result, the negative control result, staff initialing that conducted the quality control review, and any comments that that staff member felt were documentation worthy. An external quality control should be done each time the manufacturer recommends it. It should also be done anytime that a laboratory personnel is conducting a particular test for the first time. and should be conducted annually thereafter, just to make sure that, again, they are proficient in that testing procedure. Your procedural controls results in patient record. This is going to be the internal controls that the device does. So whether it's a antigen test with a lateral flow cartridge that's got the little C on there, that line lights up when the internal control is verified, to an analyzer that specifically states that the test was internally controlled was valid. Anytime that you get an invalid result, obviously that test should be either, first, it should probably be redone after an external quality control documentation was reperformed and verified that the internal controls were good. Equipment cleaning logs. And this is going to be determined, how often you're cleaning your equipment is going to be once again determined by your package insert and the manufacturer. For example, I know that when I first got started with BD and the antigen testing, it was BD recommended that you're wiping down that Veritor analyzer each and every time a test is conducted, versus our ID Now analyzers recommends that it's wiped down once at the start of the day and cleaned, and then if any sample or reagent is spilled on the device, then it's cleaned again. So knowing how often you should be cleaning the equipment is absolutely imperative to the accuracy of your tests. Temperature and humidity logs for not only the lab itself, but anywhere where you're storing your test kits. At a minimum, if you don't have the electronic trackers in your monitoring devices, should be done at least twice a day, once in the morning, once in the afternoon, and should include the date, time, the temperature, humidity, staff initials, and any adjustments that were made to the temperature, or any variance outside of the normal range, and an estimate on how long that variant could have potentially been outside the recommendations. Finally, we're getting quality assessment review form and checklist. We'll talk a little bit more about here, I think, on the next slide, and then any corrective action forms, training checklist and assessment, and device written quizzes should also be included in your policies and procedures. So what is your quality assessment review form? So these are generally conducted quarterly to annually, depending again on how big a volume, the number of tests that you're running. But it is a complete review of your patient testing process. We tend to break them down into these subcategories. So we've got patient test management criteria. Again, are we following the criteria required for initiating a test, whether it's strep, did they meet at least two of the have a +2 on the modified gas score? What were their signs and symptoms and complaints prior to COVID or influenza testing? If we're doing lipids or A1Cs, do they have is this a screening or is this a monitoring? And did they meet criteria to initiate testing? Test results and the accuracy and reliability of reports all kind of fall under the patient test management for us. Quality controls. We're going in, we're assessing our control data. Are our quality controls being done at the intervals that they're supposed to be? How many test results came back as an error from our analyzers? Were there any corrective actions or documentation regarding quality control that needed to be addressed, and what were the outcomes? We also like to review our proficiency testing, at least annually. And again, we're reviewing, is each lab member going through their annual assessments? Did any of them have any corrective actions for unsatisfactory performance or failures somewhere along the intake, testing, or collection line? And did we successfully address those issues and get them corrected? Comparison of test results. If you have multiple analyzers, we'd like to go back through and verify that we're getting similar results under similar circumstances between instruments, that one instrument's not deviating from the other. You can also compare your data to other lab or published state results from state epidemiology sites. Again, just making sure that your data is falling in line with what's benchmarked out there. Relationship to patient test information to test results. Again, we're evaluating and trying to find inconsistencies, whether it's with a particular age group, sex, diagnosis, testing parameters, anything that we need to report back to the manufacturer as a potential issue that to see if it's something that's internal, or is this an issue with the device that's known or not known about. We're going through our personnels and making sure that policies and procedures and training programs and ensuring competency and reporting of test results are being conducted and carried out as they're supposed to. Making sure that communications, that we are getting test results delivered to either directly to patients as well as their primary care providers. If there's a delay in those results reportings, or if they're missed, what's causing that? Is it a staffing issue? Is it a workflow issue? All of those things kind of fall under the communications. Complaint investigations. How many complaints did we have about the lab? What was the investigation outcome? Did it successfully resolve that complaint? This is a huge one. Any complaint, no matter how trivial, should be definitely investigated and addressed to its fullest. And then quality assessment reviews with staff. So after we've done all of our quality assessment, guess what? We need to sit down with the people that are performing our laboratory tests for us, that are collecting our samples, running the tests, sit down and go over those results with them and get their feedback in terms of what's working and what's not, what we're seeing and what they're seeing. All of that is required for, a successful, high quality point of care testing service. Documentation of staff training. So each laboratory staff member, regardless of who they are, should have training documentation. And that training documentation should include device overview and operations, reagent overview, sample collection and testing procedures, quality control procedures, results, interpretations, and invalids reporting requirements. And then they also need to be observed to make sure that not only do they have that knowledge and can pass the written tests or can answer the questions correctly, but that they can actually perform what they're saying or what they know correctly when it comes time to the tests. Again, I just included kind of an example of our training documentation checklist that we go through each year with anybody who's working in the lab for our ID Now analyzers. So each year, everybody gets to go through and have another one of these forms added and signed off on. Same with written quizzes and then proficiency testing. And this is, again, where we're sitting down, somebody's actually monitoring them and in terms of their patient intake, collection, running the tests, and checking the boxes to make sure that everything is being done to our policies and procedures, to the quality extent that it needs to be done in order to ensure accurate results. And that is all I have for you today. So hopefully, again, that was at least worth your while. And I'll hand it back over to the moderators.
It's me. We do have a few questions. For the sake of time, we'll ask the 3 questions that are in our Q&A. So let's start with, what are some screening point of care versus diagnostic point of care? Maybe they're asking what's the difference between the two.
So really, I mean, it comes down to, if you're talking about antigen testing, it comes down to, can the test actually be used to in the intended use to diagnose the disease is present. So if we're looking at antigen testing, those are screen tests. Yes, it's likely that the patient is infected with that disease, or it's likely, it's probable. But it's not a confirmed molecular diagnostic that we can say absolutely yes, RNA is present, viral material is present. It's likely. It's the difference between likely and absolute.
Okay. Let's see. Can you make a deviation for expired reagents, and what is the procedures? Is there a due date period for the deviation?
For expired reagents, no. If it is expired, then it can no longer, you cannot utilize that test as a wave test. It has to be within its expiration date.
They kind of asks a similar question for an instrument, for an overdue service for any instrument. What do you need to do
at that
for
point?
The deviation?
Okay, at that point, I would contact the manufacturer. I would contact, in that package insert, there will be a technical phone number for technical questions and specifications. I know that we had to during COVID, again, with some of our analyzers, because they didn't get staff out in time, contacted that number. They sent us the supplies and procedures in order to be able to conduct those cleanings ourselves. But that is definitely a scenario where you want to reach out to the manufacturer of that instrument, of that analyzer, and see what is the manufacturer's recommendation for how to proceed with an instrument that has gone beyond its service date.
Okay. Well, that's all the time we have. I will say thank you, Matthews, for presenting a well organized and informative presentation. And we have lots, if you can't see the chat right now, but they are asking for your presentation. So it's well received.
Awesome.
Yes.
If anybody, again, if anybody needs to see or wants, I guess, any documentation for policies and procedures or other forums just for ideas, you can definitely give them my email to reach out, and we can definitely get copies of those sent to them as well.
Absolutely. Well, thank you again. So if you have any questions after today, or if we didn't address your question, we'll do our best to reply by email. So please feel free to email us your question at onelab@cdc.gov. Next slide, please. You're invited to join us for an upcoming OneLab test event, Importance of Clinical Partnerships in Ensuring Quality and Safety of Point-of-Care Testing. It's hosted by Dr. Elise Hu. The event will take place on August 19th at 12 p.m. Eastern Standard Time. The link to join is provided in the chat. Next slide, please. And we encourage everyone to complete the evaluation for this event using the link in the chat. Your feedback on the OneLab tests or any of our trainings will help us really select future events and better understand your community needs. Next slide, please. And as a reminder, the slides for this webinar, along with links, will be posted to our OneLab test webpage within the next 2 weeks. And again, we say thank you and have a great rest of your day.